This lecture is the first of 3 lectures on the complications of diode laser cycloablation. I've been interested in diode laser cycloablation for about 20 years now, and in these lectures I'd like to share a lot of my kind of practical experience of dealing with some of the complications of diode laser cycloablation, and I've reviewed the world literature of complications as part of this lecture. Let's just start off with a little bit of history. So trans-scleral diode was used in 1990, reported by Payman. In 1991, Pollock introduced the modified G probe. In 1992, Mansour did some diode in human autopsy eyes. And in 1992, we had one of the large multi-center trials of the use of diode laser cycloablation in glaucoma. In 1995, Pfeiffer emphasized the importance of transillumination of the ciliary body during diode laser cycloablation. And then another seminal paper in 1995 by Bloom et al. Was the study from more fields of 120 eyes, which defined the basic success rate of diode laser cycloablation, which is normally around about two-thirds success. In 1996, Tsai described the use of cyclo and retinal diode in neovascular glaucoma. And then in 2001, our group described the use of diode laser cycloablation in penetrating keratoplasty-associated glaucoma. In 2002, our group was again involved with Jim Kerwin, describing the use of diode laser cycloablation in pediatric glaucoma. And also in 2002, McKelvey et al. Produced a superb paper describing the various pathological changes seen in diode laser cycloablation. I mentioned the paper by Frida Tsai, Graham Lee and myself from 2007, which, although only a short paper, is a very good introduction to minimizing some of the blinding complications of diode laser. I'm going to be talking about the 810 nanometer diode laser, and it's important to remember that there should be very low scleral absorption of this laser and very high ciliary body absorption. This assumes, of course, that there is no debris on the tip of the probe and no abnormalities of the conjunctiva, tenons or sclera, and we'll return to this later. In the bottom right-hand side of this slide, I just introduce the concept of the heel of the G probe, and the little blue arrow there is pointing to the heel, so that when we refer to the heel at later points in the lecture, you can be exactly sure of what I'm referring to.
If you enjoyed this lecture so far, please subscribe to http://iop.vision. I hope you enjoyed this series as much as we have putting it together. Thank you.